Good afternoon. My name is Dave Choksey. I'm a faculty member in the Department of Population Health, and I work for New York City's public healthcare system known as Health and Hospitals. It's an honor for me to open up this town hall this afternoon. We have with us the 19th Surgeon General of the United States, Dr. Vivek Murthy. Thank you so much for joining us today, Dr. Murthy. After I introduce Dr. Murthy, he'll make some brief remarks, and then we'll take a few questions from Dr. Mark Gurevich. Many of you know Dr. Gurevich, a visionary leader, the chair of our Department of Population Health, and the Muriel and George Singer Professor of Population Health. And then something else to look forward to, Dr. Murthy will take questions from you in the audience. Let me take a moment to also thank Dean Cheryl Healton from the College of Global Public Health, as well as Dean Sherry Gleed from the Wagner School of Public Service for co-sponsoring this event with the Department of Population Health. Across the medical center, and indeed across all of NYU, I suspect that there's a common thread that binds many of us, which is the idea that improving health is fundamental to improving opportunity. I know our speaker today shares that belief. Vice Admiral Murthy is a doctor, a humanist, an organizer, and an entrepreneur. When he was 17 years old, Dr. Murthy and his sister co-founded Visions, an HIV/AIDS education program in India and the United States, which he co-led for 8 years. After earning his bachelor's degree from Harvard and his MD, MBA from Yale, he completed residency training at Brigham and Women's Hospital and Harvard Medical School and practiced many years there as an attending. Along the way, Dr. Murthy launched a successful software technology company, Trial Networks, to improve research collaboration and enhance the efficiency of clinical trials around the world. Prior to becoming Surgeon General, Dr. Murthy served as the president of Doctors for America, a not-for-profit organization comprised of more than 16,000 physicians and medical students in all 50 states who work with patients and policymakers to build a high-quality, affordable healthcare system for all. Now, as America's doctor, he's responsible for communicating the best available scientific information to the public regarding ways to improve personal and public health. Dr. Murthy also oversees the United States Public Health Service Commission Corps, comprised of approximately 6,700 uniformed health officers who serve to promote, protect, and advance the health and safety of those in our nation and around the world. So ladies and gentlemen, please join me in welcoming Dr. Vivek Murthy, the 19th Surgeon General of the United States.
Well, thank you so much, Dave, for that very kind welcome. And it is so good to be here with all of you. How's everyone doing today? Good? That sounded kind of a little bit lame. How's everyone doing today? There we go. There we go. Well, I'm thrilled to be here, like I said. Dave is a very close friend of mine, and he's somebody who I've admired for many years. And generally, whenever Dave asks me to do something, I do it. So I'm happy. He's told me at some point I should come to NYU, so here I am. But it is wonderful to be here with all of you at such an interesting and important time for health for our country. And I'll tell you that being Surgeon General is a tremendous honor, and I've had some incredible experiences over the last year. Some of these I want to share with you. In fact, part of what I want to talk to you about today is about some of the things I've been thinking about over this past year. But this is not a role that I ever thought I would serve in. In fact, I, for much of my life, thought I would be in the private sector, starting nonprofits, working on businesses, and throughout all of that, seeing patients. So this came as a bit of a surprise to me, but it has been a welcome one, and one that I feel very honored, to take part in. I want to start, though, this conversation by stepping back and talking about the larger context of health. And as I mentioned earlier, I want to share with you some of the experiences I've had over this past year. I want to share with you some of my thoughts as they've been evolving over the past year. I've spent much of my first year as Surgeon General crisscrossing America, going to small towns and big cities, meeting with people to understand firsthand what the challenges are that they're facing in their lives. I read all kinds of briefs each day at work in Washington, D.C. I read reports, I read journal magazines, but there's no substitute for going directly to people and hearing from them about what's on their mind. And so that initial experience, that listening tour that we put together, was a very powerful experience. And in that time, I met parents who had lost children to depression and overdoses. I met teachers who are concerned that their children are dealing with obesity and early onset diabetes, things that they never saw in their schools when they were younger. And I've heard from doctors and from nurses all over our country who are seeing diabetes and heart disease at rates that they never thought they would see when they began their work in the profession. But despite all this, I've also met some extraordinary people as well. I've met people who are rolling up their sleeves and building nutrition programs so that kids can have access to fruits and vegetables. I've met people who are building physical activity initiatives to help folks in communities get more engaged in an element of prevention that we know is powerful and effective, something as simple as walking. And the people I've met and the stories that I've heard during this time have pushed me to ask myself a question again and again and again. And that question is, how do we come together to create better health for everyone? Not just for people who are living in the right neighborhoods, not for those who are privileged alone, but for everyone. And there are 4 steps I believe we need to take to answer this question, steps that I'd like to share with you today. The first is that we must figure out together how to create a culture where healthy is equated with happiness, with what people want. Right now, that's not always the case. In fact, right now, choosing healthy options is often associated with pain. Think about the onerous gym workout that you have to do 3 times a week. Or think about eating healthy food. Do many people really think that's appealing? The answer is no. In fact, some of my friends often tell me that the way they figure out what tastes bad on a menu in a restaurant is they go through and they look for what has the word healthy before it, and they try to avoid that. And it's a sad but true commentary in terms of what we're dealing with, which is a dichotomy between what's healthy and what's tasty or pleasurable or interesting. That's a dichotomy that we have to close. Now, closing this means that we ultimately need to shift the pursuit of health from a source of pain to a source of power, to a source of pleasure. The question is, how do we do that? Well, the good news is that it's being done in pockets all over our country. When I was in Roanoke, Virginia, some months ago, I encountered a program there called the Healthy Chefs Program, which students and teachers and community members are working together on in order to change kids' preference about fruits and vegetables. And what they're doing, and those of you who may have children may recognize that kids at an early age, when they're exposed to fruits and vegetables, a lot of times they like them. But we learn over time that they're to not like vegetables and fruits or to pursue other sources of food. But what this program is doing is it's exposing kids to fruits and vegetables, and it's working with the kids to actually prepare foods with those fruits and vegetables. And at the beginning of the program, they asked the kids what their favorite foods were. The kids often shared the big 3, as we call them in their list, and those were pizza, hot dogs, and macaroni and cheese. You could probably have guessed that. And my guess is that those 3 are probably on some of your lists too. But what they found is toward the end of the program, after the children had a chance to really understand and experience fruits and vegetables, that their list started to shift. And more, there were fruits and vegetables that were included in that favorite foods list. And then the kids did something else, which was somewhat unexpected, which is that they went home and they started asking their parents for the foods that they had tasted and prepared in school. So over time, the school decided they needed to be prepared for that, so they had lists ready for the parents of where they could get the ingredients at affordable prices, and they had recipes and instructions on how to prepare those foods as well. So we know that kids can have a powerful impact on parents and families, and that's what the Healthy Chefs Program is recognizing right there in Roanoke. The second step that I want to share with you is a point that's become increasingly clear to me over the years. which is that while individual responsibility is important to getting healthy, we cannot ignore the impact of the environment. We know, for example, from our experience with patients, with family, and with friends, that telling people to just go out and eat fruits and vegetables is not enough when they can't access fruits and vegetables at affordable prices in their neighborhood. We know that telling people to go outside for a walk after dinner to increase their physical activity isn't enough when they live in a neighborhood where taking a walk after dinner puts you at risk for getting robbed or being shot. So environment matters. And it's also important to acknowledge that some of the most important drivers of health disparities in our country can be found right there in the environment. In fact, right now in America, poverty, which affects 1 in 5 children, impacts access to healthy foods. It makes it difficult to simply walk outside and play. And it subjects children and adults to countless traumas, particularly from violence. So the environment matters, and when we change it, we can have profound impacts on health. This is something that they saw in West Wabasso, a city in Florida, my home state. And what they found in West Wabasso, which by the way is a city that is quite poor, which had 50% of the folks living at or below the federal poverty line, they found that investing in changing the environment produced big results. They decided a few years ago that they were going to invest in making their city more walkable by building sidewalks, investing in street lighting, cleaning up vacant lots and converting them into parks. And doing all of this, they found that a couple years later, that 95% of the residents reported that they had increased their level of physical activity. And when asked why, the most commonly cited reason were the environmental changes they had made to create more safe and walkable spaces. So the environment is powerful, and we see this not just in the built environment in streets, but we see it within buildings, in cafeterias, where simply changing the position of the salad bar and the grill can dramatically increase how many people eat salads, an experience actually that was found at the Department of Defense, which has done this at several of its facilities. So the environment matters, and creating an environment that supports health is not easy, and I want to be clear about that. We know we can't wave a magic wand and simply change the environment around us. And changing the environment means pushing back, for example, against the forces that advertise junk food to our children, recognizing that that advertising has an impact on what our children eat. It means speaking up to push for the inclusion of healthy foods in our cafeterias, in schools, and in our workplaces. It means talking to our city councils to make neighborhoods more walkable. And it also means not being afraid to say what the science tells us, which is that drinking too much soda is contributing to our epidemic of diabetes and heart disease, and that is something we have to change. The third step I want to share, I've come to believe over time, and even more deeply this past year, that in order to improve health, we cannot just focus on the body, but we also have to focus on the mind and on the spirit. When I travel around the country, so many of the conversations that I have with families are about the costs of depression and other mental health conditions that they or their family members are dealing with. I've also heard about the growing amount of stress that children and adults are experiencing that's impacting their health and their happiness. And this stress comes from different places. It comes from isolation, from family strife, from economic hardship, from violence in our neighborhoods, and far too often from the experience of discrimination, which too many people still face in our country. One of the most common things I saw in my medical practice when I was up in Boston was not necessarily diabetes or cancer or heart disease. Those were common. But the most common thing I saw was unhappiness. And I also learned early in my medical internship that we could put all the time we wanted into tailoring somebody's blood pressure regimen, into finding the exact right dose and schedule for their insulin. But if they were dealing with severe untreated depression, or if their level of emotional well-being was low, then their likelihood of following up on those recommendations and going to appointments was dramatically lowered. So the mind and the spirit matter. They have a direct impact on our body. And it turns out that there are ways that we can improve mental health and emotional well-being We know with mental health, for example, that the stigma around mental illness prevents so many people from coming forward and getting care. We know that we have to do more to integrate mental health services with the rest of our traditional medical services. We know we have to do better at paying for mental health services. These are challenges. But I want to be careful to distinguish this from emotional well-being, because emotional well-being is not just the absence of mental illness. It's not just the absence of mental illness. Emotional well-being involves thinking about how we can function at higher and higher levels so we can get greater productivity and satisfaction in our own lives. There are programs that are in place right now in our country that are successfully improving the emotional well-being of children and adults. One of them, which I had the chance to hear about in Chicago just a few months ago, is the Becoming a Man program, a program some of you may be familiar with, but which is a powerful intervention for young at-risk men that runs about 30 weeks or so, that involves a once-a-week group meeting where students are taught about integrity, about accountability, about self-determination and conflict resolution. And with that session alone, once a week, over about 30 weeks, this program has been able to reduce violence by 44% in a randomized control trial, which is a very impressive number. And it's done so at a cost that is far below what we experience when we actually see violence perpetrated in our communities, a cost which doesn't even begin to tally up the emotional toll that violence takes on families and on our communities. So emotional well-being is important, and it is achievable. It is something that can be cultivated if we are willing to invest in it and to do so. Fourth and finally, and perhaps most importantly, we have to remember and celebrate that we live in an absolutely extraordinary nation. When I travel around the country, I meet people who are full of dreams and aspirations and are working hard to achieve those. I visit schools and universities that house some of our greatest intellectual and athletic talent. And I see the diversity that we have of races and ethnicities in our country, which rivals that of any other city or country in the world. Now, why do I mention this? I mention this because it can be so easy to forget how blessed we are. It can be easy to overlook the powerful bonds that we share that compel neighbors to reach out and support each other each and every day in our country. And it can be easy to forget this because our airwaves are so often filled with voices and headlines that tell us everything that's wrong with America, that tell us all the reasons that the future is going to be dark. But it's up to us, to all of us, to reject these dark views. And we must acknowledge the extraordinary good that exists in our communities, because we cannot cultivate what we do not recognize and celebrate. In conclusion, I want to share just a last reflection on where we've been as a country, because in nearly 2.5 centuries since the founding of our nation, we have faced adversity time and time again. I know at times we can feel like it can't get any worse than it is now. It certainly felt that way 8 years ago when we were in the midst of an economic crisis. But the truth is, we have faced harder times. We have faced tougher times. But we have triumphed during those times because of our vision and our values. In fact, it was our fierce determination and our shared hopes that fueled a revolution that enabled us to create the movement for civil rights, that inspired us to rebuild this city and heal a nation after 9/11. But I'm here today, in particular, to tell you that we are called upon once again to transform our nation during a time of great urgency and need. At a time when chronic diseases cost more lives than ever before, at a time when families are being torn apart by addiction, at a time where we know we could save millions of lives if we only invested more in prevention. And that's why we need you, the men and women who have committed your lives to health, to respond to this call. This is a time for a new generation of health leaders. It's a time for a new generation that's defined not by age, but by spirit. a generation that's determined to ensure that health is no longer a barrier that puts the dreams of a child beyond their reach for no fault of their own. It's time for a generation that can restore a sense of hope and optimism to our country, that can inspire people to choose possibility over pessimism. America needs a renewed commitment to health that's rooted in this larger vision of what our nation could be. We need to strengthen our country, child by child, family by family, neighborhood by neighborhood. That's our charge. That's our collective responsibility. Sometimes people ask the question, can the world really change? Well, I believe it can. But I believe the world gets better when people choose to come together to make it so. And I believe that those people must be us. Thank you very much.
Thank you very much, Dr. Murthy. That was really quite fantastic to hear your vision and such a compelling one at that. So really, we're very grateful for taking the time today with us to share that and to enter into conversation with us about advancing health. So before we launch into our conversation, I want to just quickly address any tweeters out there to let you know that you should please reference the Surgeon General's Twitter handle, which is @surgeon_general with a very creative, I know, with the hashtag SGTownHall. If you use the wrong Twitter handle, I understand it can go to the wrong rock and roll group. So there you go.
Yeah, @Surgeon General is actually a rock band, so they get a lot of public health tweets.
So to get, well, I'll ask you a couple of questions, and here's the first one. You know, really more than ever before, there's a growing recognition that to really advance health more broadly, we need to go upstream from the healthcare delivery system and address more root causes of health. So whether it's improving high school graduation rates or even early childhood development or healthy foods, as you mentioned, safe neighborhoods. At the same time, the healthcare system is being asked to think about the social needs of its patients. Where screening for social determinants of health is being promoted. The Center for Medicaid recently announced an opportunity to get healthcare systems to assess all patients for their social needs. And so many of us who are very sympathetic to these innovations and interventions are asking, what is the limit of the healthcare system in addressing upstream determinants? Some would say that the day job of the healthcare system, which is to deliver safe and effective care to its patients, is leaving many systems struggling just to even attain an A+ on that. So how is it that we are asking healthcare to look upstream and to go beyond its traditional boundaries?
This is a time where many people and many sectors feel like they're being asked to do more and more, so often with less and less. But when it comes to health, I don't think about health as solely the business of the traditional health sector. But I think that there really is no health and non-health sector, but everyone is really part of the health sector. The question is, do they choose to recognize that or not? This is part of the conversation I have with employers, with schools, with faith-based organizations, which all have, as many of you know, an important role to play in health. Now, I don't think that healthcare systems on their own can change the fundamental determinants of health. Those determinants are massive. They take a lot of time and energy, but they also take a lot of collective effort. But what I do think health systems can do, and in particular, what I think that healthcare providers and public health leaders can increasingly do, is to be conveners who bring together employers and schools and others to recognize and embrace the role that they can play in health. Because the question is, if we don't do it as a profession, who will do it? Right? Who is going to help a business understand what interventions they should take upon themselves to improve employee health? I have employers who will often come to me and say, I recognize the importance of my employees' health for their productivity, but where do I start? Do I build more staircases? Do I invest in having mental health programs at work? Do I change the food in the cafeteria? What's evidence-based? How do I get started? How do I do this? Is it even important? These are questions that I think public health leaders can help address. Similarly with faith-based organizations, we work with a number of faith groups, which, as all of us know, have been playing an important role in health in different pockets around the country, but not often systematically. The question is, who's going to bring them together around an agenda for health? Who's going to help faith groups and employers and schools see that just as they account for money in all of their decisions, because cost is important, that they should be accounting for health in all the policies that they design and create. So when I think about the physician of the future, when I think about the nurse of the future, the public health leader of the future, this may or may not be somebody who spends all of their time delivering care in an institution. It may be somebody who also spends time in the community, understanding what people's needs are and convening folks to come together to address those determinants. But finally, to your point, this is not something that we can do alone. And it's not something that we can do with minimal resources. And because every sector is impacted by health and has a role to play in health, I think ultimately what we need is a model where more and more sectors are conversely supporting the health sector in the work that it needs to do, investing in the community programs that we know are necessary, whether they're around revitalizing neighborhoods, improving access to fruits and vegetables, or changing the kind of offerings we have around food, activity, and emotional well-being in our schools.
So to follow on that, if a community health center is being asked, or even a hospital outpatient department, to screen its patients for IOM sanctioned determinants of health, what do you think it would take for the systems to be in place for primary care physicians or others to act on the information that they then elicit?
Well, it feels very visceral to me because I remember very clearly so many experiences with patients where I could ask them about, is your neighborhood safe or not? And if they said, no, it's not, I didn't know what to do after that. I didn't know who to direct them to, who could actually help transform their neighborhood. So that is actually the second step I think that we need to make. We meaning not necessarily just a healthcare provider system, but we as a country and we as government, is to say, if we're asking providers to look into and delve into social determinants more, what is the next step for them? How can then they connect with resources through which change can really happen? In Iowa, I was actually having a conversation with some folks at the YMCA who were telling me about an interesting collaboration that formed there between the local YMCA and Mercy Medical Center. And I think this was in Des Moines, but I'm not sure exactly which city in Iowa. And what happened is that there were clinicians at the hospital who were telling patients, look, your weight is a problem, your blood pressure is a challenge, we need to get you more physically active. But patients often found it hard to do that. They didn't have somebody who could teach them about exercise and really monitor their progress. And so a lot of times they were falling by the wayside. Now in that town, there was a YMCA, which had many programs for the community to engage in physical activity. In fact, earlier this morning, I was just at the YMCA here in Manhattan.
Working out?
I actually did. I did some laps on their walking track, yes, with some other community walkers. Thanks for checking. Yeah. But what happened was interesting in Iowa is that there was, if you think about it, there was a natural marriage to be made, right, between clinicians who were recognizing a need and a community organization that was building programs to fill that need. But they couldn't really find each other. And the way they found each other was by luck, because it turned out that two of the members of the YMCA board happened to be doctors practicing at Mercy Medical Center. And as discussions were going on at the YMCA about their new project to relocate their building, these doctors started thinking, hey, there's a need here. There's a supply and demand match that's possible here. What if we relocated the YMCA, in fact, next to the hospital? So they actually did that. And now what you have for the docs at Mercy Medical Center is essentially a referral destination where they know that they don't have to feel frustrated that whenever they recommend physical activity that it's 95% not going to happen. They know that there's somebody who can follow up, who can support patients in their work. So it is that next tier of support, that destination to which we can then refer patients once we understand their challenges around determinants that we need to build and establish. I don't think that's a job purely of the healthcare system. But that's like the larger conversation we have to have with the non-health sectors.
Thank you. Let me ask you a little bit about prevention. I think the figures vary, but in the U.S., something on the order of 3% of the total healthcare spend is towards prevention. And many of us think that that's insufficient. But in an era when we're really working across the board to reduce healthcare costs, how can we see a way towards, at the same time, increasing spending to prevention?
Well, the imbalance we have with our national investment in prevention versus treatment is really insanity, and it's kind of an embarrassment. And what it's not driven by, though, necessarily, is public perception. Because if you go into the public and you ask people, would you rather prevent diabetes or get it and then treat it later? Everyone will say we'd rather prevent diabetes. People want prevention to be a priority, but it's not reflected in how we invest as a country. I'm hopeful, though, that this will change, and I'll tell you why. One is that I think as we see a shift towards different payment models, we start to see a shift toward creating more and more incentives for investing in prevention. So I think that's important, number one. The second thing is we are, within the government and even outside government, working on getting the message out about prevention, not just so that people understand how important it is, but so we can build it and bake it into policies. One example of that is through the Affordable Care Act. Many people are aware, for example, the ACA allows people to get a number of preventive-related services free, clinical preventive services. But what many people don't know about is the Prevention of Public Health Fund, which was set up through the ACA, which created the National Prevention Council, which is a body that has all the federal departments and agencies on it. And the reason it has everyone on it, from ed to defense to commerce, is because it was recognized through the ACA that health needs to be included in all policies, and prevention in particular needs to be included in policies, regardless of whether you're from a health department or not. And one of the first things that we did, and I had the privilege of chairing the National Prevention Council, which has been fantastic to see all of these departments increasingly engaged on prevention. But one of the first things that we did was to develop the nation's first national prevention strategy, which is a blueprint for prevention that we are now taking to communities across the country that can help inform local programs, help inform local and state level policies, and can also drive federal policy. So we have to keep focusing, I think, on getting the message out about prevention. We have to push out, I push on non-health sectors to actually incorporate health in their policies. We also have to push for more and more data, I think, that shows us how prevention is actually saving us lives and money. Because we know that community prevention is very, very powerful and can save us a great deal in terms of cost and suffering. But what we don't always do a good job of is translating that into policy making. And so we continue to invest way down the stream in terms of disease and illness as opposed to early on. But I think this is, as I think of it, in some ways I often say to folks that health is a branding problem, which is that sometimes, just like I mentioned with the menus earlier, the healthy option on a menu can seem like it's the boring or tasteless one. And similarly, prevention, I think, has a branding problem as well, because it's sexy to fund a new piece of medical equipment or a new blockbuster drug. It's not so sexy to fund a sidewalk that actually could play a powerful role in getting people active and healthy. But sometimes that's actually the important thing to do. And part of what can move people on this is seeing the cost numbers, because right now there are a lot of folks who don't recognize the power of prevention, and they're making decisions on policy.
So that leads me to ask you really about, as a community of researchers and investigators in our Department of Population Health and in many other centers around the university and the country, many of us are seeking to advance this agenda, such as the National Prevention Strategy. And is it really around economic data, cost data, that the greatest missing pieces that would give you the leverage or give leverage to that agenda exist? Are there other spheres as well where key research could actually help materially advance that goal?
It's a great question. So I think the cost data would be essential. The health data also, very powerful. If we can show the improvement in health outcomes and show the improvement in costs, I think these are both, especially at a time where we are battling with extremely high healthcare costs in this country, these are powerful arguments that we could make to increase our country's investment in prevention. Let me just say one addendum to that, though, and I say this with love. But one of my concerns about our profession has been that we are sometimes too content to just publish and to stop there. And publishing is important. It's really important. And that's why But we have to go beyond that. And that's why I'm so excited about some of the work that Dr. Gorovich and the department is doing here, because you're thinking about how to take the research that you do to the community. You're trying to think about how to incorporate it into education, so we're impacting how we train the next generation. But much of our colleagues in academia aren't necessarily thinking like that. For them, the end point is, did I publish in a high impact factor journal, and can I put that down in my resume for a promotion at a school that may only recognize publications as the key to promotion, which itself is a whole other issue. But this is a real problem, and this is a problem we have to solve internally in the profession, because if we only value publication as the highest order of achievement, if we keep that at the top of our list when we think about promotions, then we are going to be stuck in the dark ages in terms of impact, because we have so much power to make it with our voices. And you know why I know this? I know this not because it sounds good and pretty and makes you feel good. I know this because this is what I thought about and worked on each and every day when I was building Doctors for America with my wife, Alice Chen, who's right here, by the way. But when we were building Doctors for America, what we realized is that many doctors and nurses and dentists and PAs thought that nobody really wanted to hear what they had to say. And when we would talk to legislators, on the other hand, they were hungry to hear what healthcare providers actually had to say. Because a lot of times they were dealing with people who wanted to talk a lot about health but didn't have direct experience with patients. And that's incredibly valuable. So as I think of it, we are sitting on a treasure trove of experience and insight because of our research and because of our clinical experience. But we need to now share that with the world, and not just through publication, but by actually getting in front of decision makers, and particularly legislators, and talking to them about the experiences that you have. Sometimes when it comes to meeting with legislators, folks in medicine have an aversion to that because they think they're being political. This is not about being political. This is about advocating for your patients. Because if you don't bring forth the needs of your patients, if you don't help policymakers understand what could be really helpful to your patients, they may or may not ever know. That may not actually end up informing policy, and we may miss out on incredible opportunities to improve health. That culture change has got to be a key part of what we do as a profession over the coming years.
Thank you. A question about Surgeon General reports. So many of us associate Surgeon General's reports with really inflection points and touchstones in the national conversations about health. How about your own upcoming report or reports? Are there themes that you imagine touching on particularly strongly, and why?
Well, I'm so glad you asked, because there is a report that we have coming out later this year. And I'll tell you that reports aren't usually pre-announced. We usually announce them at the time that we issue them to the country. But we decided to pre-announce this report because the issue itself is so important. This report is going to be on substance use and addiction. And if you can believe it, there's actually never been a Surgeon General's report on substance use and addiction, which many people find hard to believe. We've been battling this problem for decades now. There have been reports on tobacco, on mental illness, on a host of other topics, all of which are important. But it's long past time to have a report on addiction. You might ask the question, well, why is the report important in 2016 when you have Google? Well, the reason that a report is important is for a couple reasons. One is because it helps bring together the best available science on treatment, on prevention, and on recovery. And it turns out that this is not always well understood by researchers, by clinicians, by policymakers, by families who are seeking to improve the system and get their loved ones' help. The second thing we want to do with this report, though, is what I think of as a cultural piece, which is to shift how the country thinks about addiction. For far too long, we've thought about addiction as a choice, as a moral failing. We haven't really seen it for what it is, which is a chronic illness that we have to treat with the same urgency, the same skill, the same compassion that we would treat heart disease or diabetes or cancer. But that's in fact what addiction is. And if we do not change that perception of addiction in the country, then it's going to be harder and harder for people to come forward and to seek help. It's going to be harder for communities to accept having, for example, a medication-assisted treatment facility in their community because they think it'll attract bad people. So this is why it's important to not only get the science out so that we can help providers and families, but also change that cultural perception. Because once the perception changes, we start to open the door for policy changes at a state, local, and a federal level. There are other reports that we'll be coming out with as well. The rest of them aren't quite public yet, but I can tell you that reports aside, there will be some important issues that we'll be addressing in 2016, including e-cigarettes, which will be an issue that I know many of you have thought about, probably encountered with your patients or with family members. That'll be an important area of focus. And the other area of focus for us in 2016 will actually be around emotional well-being, something I touched on earlier. But when I think about what building prevention into our lives, I think about the importance of thinking of it as the culture of prevention that we need to create. Because really, change is both about policy and culture. If it's just policy alone and you don't change culture, then you will never succeed. So we have to do both. And creating a culture of prevention, in my mind, is anchored in a focus on good nutrition, on active living, and on emotional well-being. These are the pillars that everyone needs, whether you're a young person or whether you're an adult, to live a healthy and prosperous life.
Thank you for that. I think it's time now to open the questions up to the audience.
It's a great pleasure to hear you speak, and thank you for your hard work in putting violence on the map as a major public health problem in this country. I think it's real. Gun violence, domestic violence, and you struggled hard, I know, to get that recognized. There's an aspect of the violence that I think is particularly important, and I'd like to comment on it. Just last week, my daughter commented to me that she feared for her life every time she got in her car to drive to work. She's an ICU nurse at LA Children's Hospital with degrees from Ivy League institutions, no mental health problems, and she's a totally law-abiding person. But she said when she gets in her car, she's not afraid of thugs on the street, but she's afraid that the police will stop her and kill her. And this is, I don't think this is anything new. This has been going on for hundreds of years, but recently there's been a lot of documentation of police killing young people of color. My question is, as Surgeon General, do you recognize this as a major contributor to the public health problem of violence? And two, if yes, would you be willing to commit some resources to trying to do something about it? Because the Justice Department approach hasn't really succeeded, and a medical approach may be more successful.
Well, thank you for that question. And first of all, I'm so sorry to hear about what your daughter is experiencing. You know, in our country, no one, whether they're a child or an adult, should ever feel that the law enforcement officials are a source of fear. They should feel safe around law enforcement officials. And the fact that so many people may not, and it sounds like your daughter may not either, is a real tragedy, and that's something we have to change. You know, your question was about the trauma that can, you know, and the mental impact, you know, of that kind of fear. And I think it's real, I think it's important, and I think it's not even just limited to fear that some folks may have around law enforcement. I think that this is a very powerful source of trauma for people when they have to live their life in fear, whether it's fear from a cop, fear from a teacher, fear from a loved one. I think that does take a toll on your psyche. And one of the things that we have realized that's frankly been known for a long time, but which we are realizing as a country just now, is the impact of toxic stress on people, not just on kids, but also on adults. And we've realized how it can have an impact on health outcomes from everything, not just from mental health, but you know, related to heart disease, related to chronic obstructive pulmonary disease. So we recognize that this is a big problem. We've actually been talking to more groups around the country about toxic stress and about how to address the underlying determinants of this. There are some great groups in San Francisco and a few other cities that we've engaged with that are looking at how to address toxic stress, which ultimately maps in so many ways to determinants, which is, I know, what a lot of Dr. Gorovich works on. But this is part of how we think about not just our campaigns, but about the national prevention strategy as well. So definitely on our radar. It's an issue that we'll continue to invest more in. And part of it is helping make sure that the country understands more about the impact of toxic stress on mental health and on overall health.
My name is Jabron Sheikh. I'm a fourth-year medical student. My question is, in light of changing political and social attitudes towards marijuana, what do you think about the lack of federal funding researching the long-term health impacts?
So good question. Marijuana comes up a lot. People are very interested in marijuana. Largely for academic purposes, I'm sure. But it's an important question because, as you know, many states have gone down the path of legalizing marijuana. A few states have done it for recreational purposes. Many more have done it for medical purposes. There's some concerns I have here, which is that we have to, when it comes to policy, especially policy around things that we're looking to use for medical purposes, we have to let science guide us and drive our decision making. And part of my concern around marijuana is that the policy has gotten way ahead of the science on marijuana. So if you ask yourself the question, do we have good enough, robust scientific evidence to say that marijuana is safe and effective for treating medical conditions? The answer is actually no right now. Is there some evidence? Are there small trials here and there? Yes. But is it sufficient evidence that you would feel comfortable approving it, that the FDA, for example, would be able to approve it for use among children and adults? The answer to that question is no right now. So research is important, as you pointed out. And one of the government has actually taken some steps to lower the barriers to do research on marijuana, which is great. The government also funds a number of studies already on marijuana to help answer the question of understanding the risks and understanding any potential benefits. So I agree that our goal should be to reduce barriers to research whenever possible. And we have to continue to invest in research. But my concern is that when we allow policy and practice to get ahead of the science, then we get into dangerous territory. Because then we're using substances for conditions and we don't know the indication. We don't know what the right dosage is. We don't know what the right contraindications are that we should be mindful of when prescribing. And all of these can ultimately contribute to harm, which is what we're trying to avoid as prescribers.
Thank you. I'm a pathology resident here, and so when Dr. Gurevich was talking about upstream effects on social determinants of health, I started thinking of Rudolf Virchow and a lot of the pathologists of the 19th century thinking about something that's very popular as a talking point now, that maybe capitalism itself or the American economic model itself is in fact a social determinant that needs to be altered. And so as a physician or as a healthcare professional, when a patient comes to you saying that, like, the fact that I'm poor, I think, is what's making me sick, how should we respond to that?
That is a really great question and a really tough question. And I'll say that, look, when a patient comes to me and when we have the discussion about where the roots of their poor health, and we realize that poverty is tied into a lot of it, I don't always have an answer for them. And I imagine how hard a conversation that has got to be for so many of you who are seeing patients who are having that recognition that poverty is driving so many of their health outcomes. But I do think that there are things that we can do. Some of them are very basic and technical. For example, just think about the fact that prior to the ACA, for many people, poverty was a reason they couldn't get insured, right? Now we know that many folks who previously couldn't get insured can now get insured with the aid of subsidies. But the problem is, actually, a lot of folks still don't know about that, believe it or not. Even though you probably feel like it's been on the news all the time, you might feel like you've been saturated with information about getting enrolled. But the message still hasn't gotten out to a lot of folks. So one thing I would say is it's so important for us to let people know about existing services that are available. And I'll tell you that after I joined the government, I thought I knew about a lot of the services that were available. There are so many more than I even knew about, which makes me proud that we've created programs that can assist folks, whether it's through the SNAP program, formerly known as food stamps, which provides food assistance, whether it's through the WIC program for women and children, whether it's through the ACA providing coverage, especially no copay preventive care services. The challenge is a lot of people just don't know about those. So that's sort of one thing, is that we have to connect people to existing resources. And I recognize that's not always easy if you are a solo practitioner out in the community and you don't have a social worker in your clinic. You can't necessarily go and research on the web and figure out all these things. So I know that that's not always easy to do. But the second thing I think that we have to do is, and this goes back to something I said earlier, is we have to make sure that our leaders, particularly our elected leaders who are making decisions on policy, that they understand what you're seeing, which is the impact of poverty on health. And as basic as that seems to you, that is not so obvious to everyone. But the more decision makers hear about this from you, the more they also understand, to come back to our research point, the economic impact in terms of lost productivity, in terms of healthcare costs of poverty, the easier it is to make the case that we need to address or target more of our policies at poverty. Because there is sometimes an overly simplified discussion of poverty in our country, which I think misses the fact that many people don't choose to be poor. They're not poor because they are too lazy to work. A lot of folks end up in poverty, sometimes because of bad luck, sometimes because they were perhaps a mom who was taking care of the whole family, and their partner, who was the breadwinner, may have passed away and they're left without any income. But they choose to take care of their children, and they're struggling with how to deal with that in the face of poverty. So telling the story of people in poverty is just as important as making the connection between poverty and poor health when you're talking to decision makers. And I can't emphasize just how important that is. We tend to think of ourselves sometimes as practitioners as being technical providers. We provide expertise in reading a pathology slide. We provide expertise in doing a cardiac cath, in making a diagnosis of hypertension and recommending treatment. But we are not just technical providers. We are also storytellers. That is and has always been our role historically, going back centuries as physicians. But we've lost touch with that over time. And I think that one of the most powerful things we can do to address not just poverty, but other social determinants of health, is to reclaim our role as storytellers and to make sure that our decision makers, our elected leaders who craft policy, are hearing those stories and hearing them often.
Dr. Shelley.
Hi, Donna Shelley from the Department of Population Health and College of Global Public Health. My question is about scale up, and I was struck by the couple examples you gave of effective programs, and at the same time it triggers incredible frustration for me, because there are thousands of those kinds of examples, and they really never get to scale. So how is your national prevention strategy? How are you systematizing something like that, and is that strategy working on this idea of scaling up the things that are working all over the country?
So this is a really good question, and that frustration that you felt about these programs not being scaled up, that's echoed by so many of the groups that we meet that are doing these successful programs. Because there was an emotional well-being program that we visited in San Francisco just a few months ago. It's a program that has a 30-minute intervention each day that they do for kids, 15 minutes twice a day. It's a very simple intervention that's actually based on meditation. And they have, in a city, in a school that's in a very violent neighborhood, they've been able to, in 1 year alone, with this simple intervention, decrease suspension rates by 45%, decrease teacher absenteeism by 30%. They've seen grades and test scores skyrocket, self-reported anxiety scores drop, students are reporting they're sleeping better. So many extraordinary improvements. But the frustration they have is they say, we don't know how to get this out to more schools. They've gotten it out to a handful. Those schools have actually had equally impressive results, but they're not sure how to scale. So I said, what's missing for you? And what these groups often talk about is they say, well, one, we don't feel like we have enough research support to study our program to then be able to justify more investments in the program, because we need the funds to be able to do the research to show people it works. And it's, as many of you are familiar with, that can be a not so virtuous cycle. The other thing, though, that they need, in addition to the ability to do research, is they need people who can tell their story. And I come back to this idea of the importance of storytelling. And this is where I see our role as the Surgeon General's office as being important. Because in Washington, D.C., there are two well-accepted and recognized sources of power. Those are money, if you have a large budget. And the second is legislative and regulatory authority. So if you can make laws and make regulations, that's a big source of power. As it turns out, our office is neither. But what we do have is a third source of power, which is a soft source of power that's largely unrecognized in DC, but it's very important, which is the bully pulpit, to actually communicate and tell stories, to bring people together, to convene around an agenda, and to actually set an agenda for the country, as the Surgeon General's office has done on tobacco and on many other issues over the years. And this is actually one of the things that we want to help do, is to see, can we take programs like that are successful and help tell their story? Can we go beyond telling their story and help bring people who are funders in this space, who are looking for successful programs to study and to scale up, and bring them together to actually see what's out there? Can we also bring the players together in these fields, the different programs that exist all over the country, to then help discuss successes and map out a focused agenda for the country on topics like emotional well-being, for example? So that's an important role that our office is looking to play over the next couple of years. But I'll lastly say that I don't think the solutions for scale are always in the government. And I know you weren't saying this, but I just want to be explicit about this. Sometimes we see programs that work and we think, well, if we were just a federal program that made this happen everywhere all around the country, it would be great. And sometimes that works, but it doesn't always work. So I think we have to also be looking for private sources and private mechanisms and avenues through which to support large-scale programs. There are examples of how we've done that in the past, and I think we need to keep that in mind as we're looking to the future and looking to scale up these successful programs.
Okay, final question.
Final question,
Go
right
on.
in the front here.
Hi, my name is Albert St. Jean. I'm a researcher with Population Health. So speaking about diabetes and heart disease, I wanted to know, because so many of the unhealthy food options are directly or indirectly subsidized, is there a way on the policy level to maybe reverse that, to maybe redirect that towards healthier food options, subsidizing them and making that more accessible?
So I appreciate the question. I think what you bring up is an important point, which is that subsidies and government policy can have a powerful effect on our food supply and on what foods actually end up on your grocery store and your dining room table. And what I would love to see us do more of is to put our emphasis on making fruits and vegetables actually easily and more available to people. If we did that, I think we could have a dramatic impact on health. For example, if you increase on average the amount of fruits and vegetables that people are having by one serving, like on average, that results in about approximately 4% decline in their risk of developing cardiovascular disease. And that actually goes up significantly to double-digit reductions, the more servings they have of fruits and vegetables. That's the kind of support that we need, I think, is to get fruits and vegetables more out into our communities as opposed to unhealthier food. Now, your question is what's really going to change that, right? And ultimately, I'll come back to the point I made earlier, which is that in order to change that, we have to help our decision makers understand the connection between the policies that we have, the food that's ending up on the tables of the patients we treat, and the health outcomes that's ultimately creating. Sometimes people need to hear that and understand what the connection is, and sometimes they need to understand how passionately you feel about it. I had a member of, well before I was Surgeon General, I had a member of Congress who once told me, he said, our office gets a lot of phone calls from constituents, and we make notes of what the issues are that they're talking about. He said, but if a doctor calls or a nurse calls, he said, that's unusual, so we list it down as sort of a notable event. Says, by the way, how infrequently doctors and nurses actually call to share their views. He said if 10 doctors called us in one day, that would be a full-blown crisis. Something's definitely going on. That is such a low bar. It's really low, but it speaks to the lack of engagement that our community of providers and researchers has had over the years when it comes to engaging with decision makers and helping them understand what our patients need and also understand what our patients don't need and what might be hurting them. And that's why I believe that if we are able to bake into our culture as a profession, not just providing skilled care, not just providing compassionate care, but also a role in storytelling, in advocating for our patients, then I think we can be a much more powerful force for changing health in our country, whether it's around the built environment, whether it's around subsidies, whether it's around access to fruits and vegetables and other healthier foods.
So I want everyone to join me, please, in a warm round of thanks for We really very much appreciate your being with us and sharing this very broad vision for achieving greater health for our country. And we wish you, on behalf of all of us, really every success in getting there from here. So
Thank you so much, everyone. It was really wonderful to be here.